it's indeed an honor and a privilege to have none other than Dr. Robert Coleman on the program this evening or this morning from his perspective, and my colleagues Dinesh and Dr. Jyoti Vadva to be on the program delivering lectures on various aspects of ovarian cancer. We know that the biology of the disease is such that we are faced with recurrent disease in majority of the patients, and once these become refractory to platinum, then the challenge begins. So this disease largely remains a challenge still in the clinic. The VEGF inhibition, the PARP inhibition, and the research of the last decade and a half has given us more leads and more possibilities to treat our patients better, but the challenge continues to be there. Without further ado, I would pass on the proceedings to Dr. Coleman to deliver the first lecture on the current status of PARP inhibitors in epithelial ovarian cancer. Dr. Coleman, as I said, it's indeed a privilege and an honor. Good morning to you and good evening to all my colleagues from this part of the world. And we have 344 registrations at this point in time. And we do hope that as the program progresses, more people will join in. He doesn't need introduction to the gynec oncology professionals and to this part of the world. He's a familiar figure. He's the president of the IGCS, President Society of Oncology, Chief Scientific Officer at the US Research Texas. And over to you, Dr. Coleman, to deliver your talk on the current status of PARP inhibitors. Thank you so much once again for joining in, and we look forward to a great interactive scientific session.
Thank you so much, Jacques. It's so great to see you. I wish we could do this face-to-face. Seems like this is the only way we get to meet these days, but it's going to change. I know it. I got it. I feel it's going to be good, or I'll be able to be with you in person and meet with your wonderful colleagues. Thank you so much for the invitation, and I'm so happy to join you today. This is a great time with respect to ovarian cancer management. There's been a lot of work that's been done. I don't know if I just actually saw in my email as I was listening to the introduction that another paper of another PARP inhibitor in the recurrent setting, fuzolaparib, just was published. Just goes to show you how much interest and excitement there is with looking at this modality of therapy in ovarian cancer management. I'm going to focus, because there's so much to talk about, I'm going to focus in the primary setting because that's where most of the impactful work is being done right now with respect to the natural history of this disease. And I thought that what I would do this time, these are my disclosures. What I thought I would do this time is actually start with a case. Since this is a master class, I thought it might be nice to start with a case, probably similar to what you guys see. There's a patient, 63 years old, who complained of abdominal distension, cough, and pain. She had mild hypertension, has no real family history for GYN malignancies. And she had significant shortness of breath on the right-hand side of her chest. She had an abdominal distension with a fluid wave and a mass that was palpable and would come back to the surface in a blottable kind of way. And of course, in her pelvis, she had nodularity in the cul-de-sac, and it was actually quite fixed there. Her CA125 was elevated, not tremendously, but at 231, and she had relatively low albumin. It's highly suspected ovarian cancer, so we ended up getting an imaging study, and this was her CT scan. This shows the ascites. You can see here she has this large complex mass in the pelvis that is, which was consistent with the physical exam. You can see that she has a portion of her rectosigmoid colon kind of trapped between the bony pelvis and the mass. And then in the upper abdomen, she has a mass here in diaphragm along the side of the liver, some momental metastases, fluid in the upper abdomen with some nodularity, and as suspected on exam, fluid in the chest. So quite extensive disease. Normally in this kind of patient, we would evaluate the abdominal disease laparoscopically to assess for to assess for resectability, but it was clear here that she had was unlikely to do well with primary surgery for complete gross resection. So we ended up biopsying this mass, which showed a mixed endometrioid serous high-grade lesion. And as such, she was triaged to neoadjuvant chemotherapy with paclitaxel and bevacizumab. She did have germline testing done at that time, which basically showed no deleterious mutations in BRCA1 and 2. But following 3 cycles of therapy, she had a dramatic response to her effusions with near resolution of her disease. So almost unexpectedly high degree of response. So when she went to surgery, she had a complete gross resection, and that tumor was sent for testing. And although we found no deleterious mutations in BRCA1 or 2 or any of the other homologous recombination response genes, she did have a high genomic instability score. This is the Myriad test, it's 52. And so she was treated with 1 additional cycle without bevacizumab and then completed cycles 5 and 6, at which point in time we did a complete evaluation, including an imaging study, which showed actually resolution of disease, a CA125 that normalized. And of course, at that time, then we administered olaparib along with her bevacizumab as aligned with the PALA-1 regimen, which is approved for this indication in the United States. And she's done quite well. So a kind of a typical story that we see with ovarian cancer, in a way, from the standpoint of presentation, probably not a typical presentation with respect to the response to therapy, but reflective of the genomic findings that we found in that case. And so as we look at ovarian cancer over the last several, few decades, you can see that, at least in the United States, that the incidence and mortality rates have been declining at about the same pace. So obviously, an incident case, let's say in 2010, would show up in the mortality statistics sometime in 2013 to 2015. And so, but you can see that the pace of new cases and the pace of deaths are basically parallel. And so what we're seeing here is that we're not increasing the cure rate because that pace is basically parallel, but we are seeing overall decline in incidence mortality rates, which are remarkable. But really what I think is more impactful, and I've used this slide frequently because I think it helps us to understand the burden of disease, what we're trying to accomplish, and that's that there's an increase in prevalence, which means that that there are more patients around, the more patients in those clinics that you're going to visit that actually have this diagnosis of ovarian cancer, and that's increased dramatically, 40% increase, and this is happening in the setting of a 34% reduction in incidence. So you have this lower level of new patients, but a higher number of patients with disease. And so if you think about that, the only way that can really happen statistically or functionally is that patients are living longer with their disease. And you can see there's a pivot around 2014, 2015, where there's a big jump in increase that basically establishes, I think, a reflection of 2 principal elements with respect to therapy, and that's the introduction of bevacizumab and the introduction of PARP inhibitors in the frontline setting. So I use this graphic a lot because I like it as a way to present the natural history of ovarian cancer from symptomatology to supportive care and death. And the highlight I want to say here is that it wasn't so long ago that the progression-free survival of this disease was around 12 months. If you go back into the taxane platinum era, that's about what we saw. And the post-progression survivorship, because of the lack of available therapies that were efficacious, was about 12 to 14 months. And so it was not unexpected to think about a patient with ovarian cancer to have a median overall survival of around 24 to 32 months. But in recent days, because of these alterations in how we approach surgery, how we give chemotherapy, and the introduction of maintenance therapy in both frontline and in the recurrent setting, our expectation for patient survivorship is now right at 5 years for the median in the United States. So tremendous progress been made in a relatively short period of time. And as we think about where PARP inhibitors fit into this narrative, you can see that we have it annotating much of that treatment paradigm. So as many of you know, we started out with therapy in late stage BRCA annotated patients with a PARP inhibitor, olaparib. That was moved into a line earlier with rucaparib. Then we had the 3 trials that now 4, actually now 5 trials that have basically shown the benefit and merit of maintenance PARP. And then we moved it into the frontline setting. So we started over here at end-stage patients, and we moved it over here into the intent to treat population of patients who responded to chemotherapy. We actually have a treatment a study that we did where we gave PARP inhibitor concomitantly with chemotherapy and its maintenance. So you can see with all this activity over the last 2 decades, much of this happening within the last 10 years, we have annotated this entire treatment paradigm with the role of PARP and actually anti-angiogenesis therapy. So why do we pay? Why do we care? Well, one of the things that we focused on, obviously, in therapeutic space, is try to find a differential cytotoxicity between normal cells and cancer cells. And of course, chemotherapy is a blunt tool to use for treatment of cancer because it focuses on a principle that cancer cells divide more frequently or rapidly than normal cells. And so these alterations that are made, such as adduct formation and nucleotide substitutions and deletions as part of therapy, can lead to cell death that's differential to normal cells. But we know that as we destroy or try to destroy differentially DNA, there are many cellular processes that are around to try to keep the cell alive. One of those that is very pertinent to this discussion is the repair of a catastrophic injury where there's actually loss of genomic material, and that's a double-strand break in DNA. And that in this way, the process of homologous recombination is entailed to actually fix this defect, which is a very energy-intensive process, but it's done with high fidelity to restore this particular defect of DNA. Now, we know there, as mentioned, there are multiple other components of this. A single-strand break obviously is a relatively easy injury to fix because the base read, knowing that A and T and G and C have to align with each other. If you know the template here, it's relatively easy to fix this. And this is governed by a process that we actually are trying to target, and that's PARP. So the hypothesis here, and this is just a graphic everybody uses, I like to use it because it's instructive, is that if you have this defect in loss of genomic material here on a strand, and you have the template from which the opposing strand can be read, PARP fits into this space and recruits nucleotides to fix this defect with relatively high fidelity. But if we block this or trap it pharmacologically on the DNA, it leads to a probability for a double-strand break, which leads to that dependency on homologous recombination for normal repair. Now, there's many proteins, and I'll come back and visit this in a minute, that are responsible for the high fidelity repair. But if you're not familiar with homologous recombination, the process involves providing a read frame of missing genomic material based on the sister chromatid. As we all have 2 copies of all genes in our body, this sister chromatid serves as a template that becomes invaded by a strand of DNA with missing material, and then can read the missing template here to provide restoration of that DNA read. So it's a very complicated process that involves multiple steps. And you can see that BRCA1 and BRCA2 are principal and integral to this process being done with high fidelity. So the process in a cancer cell, if they have deficiency in that repair mechanism, is that we can lead to a differential in cell death. This therapeutic window between a normal cell surviving and a cancer cell dying. So PARP inhibition leads to a probability of an increase of a defect that a cancer cell can't deal with it if it's missing this function, but a normal cell can. So PARP doesn't directly affect the cancer cell, but it increases the likelihood that the cancer cell will be vulnerable if they lack homologous recombination. And that's important because if the cancer cell has compliant homologous recombination, it will not be sensitive to a PARP inhibitor, or shouldn't be. Okay, and so that's going to be important in the way we treat those patients. Now, this hypothesis was tested in the lab about 15 years ago. 2 papers came out in Nature, and they basically showed that cell lines that were biallelic deficient, again, both strands now of the DNA are lacking BRCA, were exquisitely sensitive to a PARP inhibitor. So it's important to know that even though there may be a mutation in one of the strands, if the second allele is intact, this cell survives. So biallelic loss in BRCA, where there is lack of homologous recombination, shows exquisite sensitivity to a PARP inhibitor. And we pay attention to this in ovarian cancer because BRCA mutation in either as part of the germline or as a novel event in the tumor happens in about a quarter of our patients. And then among all these other genes that are responsible for this compliant pathway, about another half of the patients, or excuse me, another quarter of the patients make up the potential vulnerability for this to execute on this differential pathway. So in all, we see about 45 to 50% of our primary ovarian cancers as patients that may benefit from a PARP inhibitor, banking on the hypothesis that homologous recombination is not compliant. Now, we had early evidence that this hypothesis was real. And I just present to you this publication in 2009. And remember, we had cell line data in 2005. And in 2009, we had a study reported in the New England Journal of Medicine as a phase 1 with a PARP inhibitor. So only 4 years between discovery and publication. Phenomenal. But this was something that we could identify. We had patients who had either a strong family history or were known to be germline positive in BRCA. They had recurrent ovarian cancer. We gave them a PARP inhibitor. And even in the patients who had platinum-resistant disease, that's these group here, and refractory patients, we did see responses. Now, obviously, the responses were stronger in patients that had platinum-sensitive disease, or they were more frequent. But they did see patients across the spectrum. So this was very early evidence that something was really here, and we actually moved on this quite quickly. Now, we also learned in the process of this discovery work was that there were cells that actually had intact BRCA1 and 2, but still carried a signature that demonstrated that there was lack of homologous recombination. We call it, in this particular example, is loss of heterozygosity. So if you look in here at the upper panel, tumors that have a mutation and dysfunctional BRCA have high degree of loss of heterozygosity across the entire genome, and this is unexpected. So in these tumors that had a similar phenotype here of a signature, were thought to be potentially BRCA-like, and maybe, just maybe, they would respond to treatment like these BRCA patients did. And these were to be distinguished from patients where there was lack, or tumors that had lack of loss of heterozygosity and basically functioned as normal, compliant, homologous recombination cells. So we had discovered in the process that we could identify these characteristics, and now there's several commercially available tests. This is just one of them that isolates this distribution of cells of tumors that actually demonstrate high degree of genomic instability that is aligned with what we see in the BRCA patients. So these green bars represent the frequency of genomic instability scoring in tumors that are lacking BRCA. And you can see in the teal area that these cells have actually a similar degree of which, and that we would call that genomic instability, or HRD test positive. So we had also evidence around that time, this is an abstract I presented a few years ago, in looking at a different PARP inhibitor called rucaparib that demonstrates this. So we took patients, nearly 100, who were BRCA wild type but had this signature, and we looked at their objective response rate against the patients who were BRCA wild type but did not have the signature. And you can see there's about a tripling of the objective response in these patients. Now, it's not as good as BRCA, but it is definitely demonstrated an effect in therapy. So the hypothesis seems to be very strong, and because of that, we moved that treatment paradigm from the recurrent setting into the frontline setting. Now, I just want to mention 2 quick points about genomic instability. There are tumors that have low level of genomic instability, but they are have BRCA mutation. And this is some work that was presented by Liz Swisher and her team and Charlie Gorley, where they took the patients that were studied in SOLO-1, and they looked at those just distributed by their LOH score. So this is one cutoff, and this is a second cutoff. And you can see that despite the fact that these tumors in these dotted lines here had low LOH, but BRCA mutation still had the same degree of efficacy. And this shouldn't surprise you, because if you look at the synthetic lethality, that's the term we use for this, the synthetic lethality of BRCA-like genes, or excuse me, of genes that are involved in homologous recombination, not all of them act like BRCA. So over here at the side, you can see BRCA1 and BRCA2, high degree of cytotoxicity in the presence of a PARP inhibitor. But if you look over here, you can see that, for instance, CHEK2, RAD51D, FANK-G these are proteins that are involved in homologous recombination, but they show no as an isolated gene mutation, show no cytotoxicity in the presence of a PARP inhibitor. So these genes are responsible for homologous recombination, but they work in combination. And so it may not be enough to have a single defect to do that. And so that becomes very important, because many people focus on homologous recombination gene mutations as opposed to genomic instability. So I just want to highlight that. Okay, so here's the frontline distribution now. I keep adding to this graphic because now Athena was just added. We'll know, I don't have all the information about Athena yet, because it will be presented at ASCO. But you can see now we have 6 trials that have been done in the frontline setting that have added a PARP inhibitor to in the maintenance setting. Most of these are pure maintenance versus placebo, although one of them, PALA-1, was comparing olaparib and bevacizumab to an active comparator of bevacizumab. And so I'm not going to go through this list, but you can see that there are various differences here with respect to how the trial was set up with randomization, what the duration of the PARP inhibitor was used, the patients that were studied, the proportion of BRCA mutation, if they had a genomic instability scoring, what was done and how that testing was used, and what the primary endpoint was based on either investigator or a blinded independent review. So I'm going to walk you quickly through these trials. I know you know them well, but I think they're instructive to review, basically given all that history I just gave you with respect to how these drugs work. So SOLO-1 was the first of these trials. Remember, 2005, cell line, 2009, phase 1 study, and now in 2018, first phase 3 study in the frontline setting. So a very short timeline with respect to drug development. So SOLO-1 took advanced stage patients who had either germline or somatic mutation in BRCA, and they were randomized 2-to-1 to olaparib versus placebo. The primary endpoint was an investigator-assessed progression-free survival. This particular trial pre-specified 2 years of treatment with olaparib if there was no evidence of progression during that time frame. And the data that were released at ESMO that year in 2018, for most of us, was very eye-opening. Really a celebration of marrying biology and an intervention with a predictive biomarker. And you can see these curves are widely separated. At the time, there hadn't been a median reached in the olaparib arm, but most importantly, the hazard for progression or death was reduced by 70%, 70%. Very, very impressive data. These were updated late last year by Susanna Banerjee that added a couple more years of follow-up. And you can see in this analysis that the updated data basically confirming the frontline data of a hazard ratio of 0.33, which represents a 67% reduction in the hazard for progression or death. But what I want to point you to in this particular graphic is that from about 4 years on, the event rate is becoming extraordinarily flat, and this, which is very similar to what we're seeing in the placebo. So the hope is here that these patients are actually represent new cures. And hopefully we'll get a discussion on what that means, cure means. But this is obviously hotly anticipated for a future meeting. Now, because of the efficacy in that population, and I'm not a big fan of using this criteria of higher and lower risk, but it is used to support the use of bevacizumab. I'm not a big fan of that, but I will say that these analytics of looking at higher and lower prognostic cohorts with respect to their stage 4 disease and response to platinum didn't really matter. In fact, there seems to be a very strong and consistent effect in this population of BRCA patients with olaparib treatment for their hazard ratios being almost identical, 0.33, 0.34. Now, PRIMA was a trial that was done to try to catch up for their PARP inhibitor, niraparib. It was done in a higher risk cohort of patients prognostically. So these were patients who had had a lot of stage 4 disease, suboptimal cytoreduced, and actually did not have complete resolution of their disease at the time of moving into the maintenance setting. And it was looking at a longer potential duration of niraparib of 3 years versus 2 years in SOLO-1. But it was also looking at the adjustments of the total dosing based on the weight of the patient and platelets. So this is a prospective evaluation of this new dosing scheme. And this particular trial had 2 endpoints. The first endpoint was to look at the role of the niraparib in this patient population who had homologous recombination deficient tumors. That included BRCA and the BRCA wild type homologous recombination test positive patients. And if that was positive, the alpha was passed on to the intent to treat population, so all comers. And of course, this study, which represents a higher prognostic risk population, did not have as high of the medians, particularly in the placebo group, but it demonstrated consistent effect with a hazard ratio of 0.43, which is a 57% reduction in the hazard for progression or death at every point of exposure on this curve. So you can see it was highly statistically significant in this HR deficient or HR test positive case population. And because that was positive, the alpha was passed on to the intent to treat population, which is listed here. And because this was positive, the FDA looked at the subgroups and determined that there was potentially an effect seen even in the HRD test negative, but HRD test negative cohort. And so they got approval for niraparib in all comers. And the third study in this kind of narrative is the PALA-1 trial, which, as I mentioned, was looking at a olaparib versus placebo in patients that were receiving bevacizumab. So for me, this was more aligned with the patient case I presented and aligned with my typical practice. In this trial, there were also 2 primary endpoints. One was the investigator-assessed progression-free survival. The other was the progression-free survival 2. And so in this particular study, about half of the patients had homologous recombination deficient tumors with a little higher proportion of BRCA positive patients. But ultimately, this trial, again, demonstrated the merit of adding olaparib to bevacizumab. And you might say, well, listen, this hazard ratio isn't as strong. But remember, the comparator here is not placebo. The comparator here is bevacizumab. So we have an active comparator, which was actually positive. And again, as they did with the PRIMA trial, the FDA in the US looked at the HR test negative patient population and did not see a signal. And so even though this was not an analytical endpoint, they carved out this population and made the approval for patients who had HRD test positive patients. The secondary endpoint of this trial, as I mentioned, was PFS2, and it demonstrated a statistically significant improvement in the time to second progression. And you can see that was there with the tail of the curves. Unfortunately, there was no new toxic events. You can see that these toxicities on the right-hand side of placebo represent the toxicities that we see with bevacizumab. We did not see any additive effect with the PARP inhibitor, which was reassuring. And again, because this is really a trial that's material to the use of bevacizumab based on what many countries approve, their health authorities approve bevacizumab for, there actually seemed to be a stronger effect in the cohort of patients who you would not give bevacizumab to if you followed that high risk, low risk criteria to use bevacizumab. You can see the hazard ratio in the low risk patients with bev and olaparib was 0.15. So highly, basically to me tells me that that the criteria are probably, and were always post hoc and were hypothesis generated, but they were not definitive. So these are the trials now kind of all lined up against each other. And you can see all the long bars to the right here represent the medians that we saw in these trials, demonstrating the efficacy of this therapy. I think now annotated well in our guidelines. You can see that bevacizumab is added as an early point of decision. There is next a decision that's informed by BRCA testing. This is being done in the germline and the somatic. And then a third point of testing based on genomic instability scoring in patients who are on the bevacizumab arm. And that has basically annotated our population. So there's more coming. As I mentioned, ASCO, there will be a presentation on Athena, which is looking at rucaparib versus placebo. And we have 3 other trials that are looking at PARP in combination with bevacizumab and immunotherapy, all of which have enrolled, and we're waiting for events. So I hope we give you a good update on just where this disease field, treatment field, this landscape is going with PARP. I'm very excited to see this continue to mature, and I believe this represents a true benefit for our patients. Thank you so much for having me.
Thank you, Dr. Coleman, and for that wonderful exposition. And I take this opportunity to pass on the proceedings to Dr. S.P. Kataria to take the discussion and the rest of the proceedings forward from here on. Dr. S.P., are you there? Yes.
Good evening, sir. Well, you all can hear me?
Yes.
Yeah. Thank you, Dr. Coleman. I think you have done a wonderful job of what the PARP inhibitors are there today. How they all actually came into picture in 2005. And, so quickly they have matured. Like in last 5 years, we have had at least 11 new molecules. And with the number of clinical trials going successfully, we're hoping we will get some more options within very near future. So thank you so much, Dr. Coleman, for this. For taking us through all the trials, through all these trials, through PARP inhibitor trials, through the journey. Thank you so much, sir.
Thank you.
Okay. Thank you, sir. Continuing with our program, we now have Dr. Dinesh Pandharkar. He is Director Oncology in Sarvodaya Hospital, Faridabad. He is also Chairman of the National Cancer Society. He is the past President of ISO and ISMPO, and he is past Chair of International Affairs Committee of American Society of Clinical Oncology. He is going to deliver a talk on the advances in the management of platinum-resistant ovarian cancer. Dr. Pandharkar, please. Thank you.
Good evening, everybody. And it's
Yes.
my honor and pleasure to share this platform with all of you and Dr. Coleman. I had designed actually my presentation in a way that I really wanted to just set the ball rolling because the problem is so common and all of us are so much used to this problem that it really does not require a discussion. But what requires a discussion is what is happening now. So what is happening, Dr. Coleman has just told us, the PARP inhibitors, the bevacizumab, and using both of them together. Next slide. So I just want to bring out some data on ovarian cancer. So this is incidence of ovarian, this is the incidence of cancer in America in 2020. Remember this figure? Next one. Next slide. And if you see the incidence of ovarian cancer in America, there are 23,820 new cases in 2020, with 5-year prevalence of about 72,000 women. So 23,820 in a year and a 5-year prevalence of 78,000. Next slide. This is an Indian data. So it's 1.3 million against 3.3 million in America. So we are about 2.5 times less than America in an yearly incidence of cancer patients. Next slide. If you see the incidence of ovarian cancer, it is 6.7 per 100,000 population. But what is more important, next. Now, if you see ovarian cancer incidence, we are in first 10 in the incidence of cancer with 45,000 new patients per year in the year of 2020. So again, despite our incidence being 2.5 times less than in America, our incidence of ovarian cancer is double then. It's 45,000. And if we take the 5-year prevalence, it's more than 100,000. So I just want to bring to you a point that ovarian cancer is in true sense a big issue in India, and we have to start focusing more and more on this cancer. If you go into the periphery, so when I go to districts of India, you will be surprised to know that I have districts where the ovarian cancer stands literally fourth in the prevalence of patients in the clinic. There are clinics where practically we don't see cervical cancer, but there is an ovarian cancer. I just want to stress that it is really a truly big problem in the country. It is only next to breast cancer in many districts. Next slide. So 5,000 women in a year, new patients with a prevalence, 5-year prevalence of 103,000. Next. Next. So if we really see, we know that paclitaxel, paclitaxel carboplatin had been always a standard of care. So there had been data of using 3-weekly paclitaxel and 3-weekly carboplatin versus weekly carbo, weekly paxil. So this graph I'm just showing you with one of the latest data from ICON 8. I just want to focus not on the data per se, but if you see the graph of how patients behave, nearly at 18 months to 24 months, 50% of the patients have already relapsed. And by year 3, there are only 25% patients remaining in remission. That means majority of the patients are coming back to us with the disease, irrespective of paclitaxel carboplatin, which is our standard backbone for the management of ovarian cancer. Next slide. If we see another data, next slide. So this is another data which again compares multiple regimens which are prevalent or which had been prevalent, I would rather say, cisplatinum, paclitaxel, gemcitabine, and so on and so forth. And if we see the progression-free survival, it's another trial, GOG trial. Again, the data is absolutely same. That at the end of 3 years, only 20% remaining progression-free. Even if you operate them well, and even if you leave a disease which is just more than 1 centimeter after the surgery, and my colleagues would appreciate whenever we are doing a surgery in this country, we know how much residual we are leaving. I don't have to tell you. And if that factor also predominates, so if you have a chemo done and if you have a surgery done with a residual disease of some size, literally more than a centimeter, then the survival further drops. Next slide. And if you see the overall survival, not only progression-free survival, even the overall survival is very, very low in ovarian cancer. So what is our standard of care today? It's paclitaxel carboplatin. Generally 3-weekly regimen. Some of us might be using weekly regimen, interposing with surgery, either upfront or cytoreductive surgery in between. Ultimately, most of our patients are relapsing. So when I was asked to talk about a platinum resistant disease, whatever we say, it is irrespective of the time, 75 to 80% of the patients would relapse. It means basically 80% of the patients are platinum resistant. It's only a matter of time, whether they are resistant today or whether they are resistant tomorrow. So I personally feel from our perspective, every patient is a platinum resistant. This is not to discourage you, but to tell you that there is a dire need to make a change in how we approach ovarian cancer. So my job today basically was to tell you that the platinum resistance is there literally in every patient. Next slide. Yes, we do divide patients into platinum sensitive patient and platinum resistant patients. Next. So basically, what is a platinum free interval? It's a time from diagnosis to first relapse when platinum was part of the first treatment. Next slide. So as per GOG, yes, there had been multiple definitions like a platinum refractory disease where the progression happens while receiving last line of platinum, literally within 4 weeks of treatment. Platinum resistant disease, when the progression free interval is literally within 6 months of last platinum installation, or a partially platinum sensitive disease when it's between 6 to 12 months, and a platinum we call it platinum sensitive disease when we have crossed 12 months of progression free survival. But literally, as I said, for us as clinicians, if we really want to make a change in ovarian cancer, practically every patient is a platinum resistant patient. It's only a matter of time whether the patient is platinum resistant today or platinum resistance tomorrow. But they are all platinum resistant. All of them, patients in stage 3, stage 4 disease, they all come back to us. And in my practice, and I'm sure in your practice, 70 to 80% of the patients form a bulk of stage 3C disease to start with. So basically, we are dealing with a platinum resistant group of patients, and there is a dire need to do something else. Next. As Dr. Coleman has just said, that the median survival in platinum sensitive disease is about 2 years, with a range from 3 to 10 years, and in a platinum resistant disease, it's 9 to 12 months. Next slide. Why and what this platinum resistance is? Till date, we have really not been able to define what means platinum resistance, how it comes, how it happens. Probably, as we are seeing 80% of the patient's disease coming back, that means biologically, ovarian cancer is destined to develop platinum resistance. This may happen because of changes in the cancer cells. This may happen with a change in P53. There are a lot of genome-wide variation mutations which have been detected. There are epigenetic changes, dysfunctional DNA repair mechanisms. And what is more interesting and has been defined is there are cancer stem cells which literally remained dormant all through, where platinum has no effect, and then they emerge as a major clone after some time. Similarly, there is the EMT mechanism, the mechanism of epithelial to mesenchymal transition plays a big role in ovarian cancer. Why all these biological aspects are important? Because these biological aspects will actually allow us to base our management of ovarian cancer in the future. PARP inhibition, bevacizumab also is a part of knowledge of these genetic changes which we are recording. I am sure with time to come, we'll be able to see even more usage of this particular information in deriving new management, new treatment strategies. So the chemo regimens which all of us are used to in platinum-resistant disease, be it liposomal doxorubicin, topotecan, irinotecan, all these things do help us in managing patients for some time. But unfortunately, every second disease-free survival or progression-free survival time is lesser than our first time of progression-free survival. So the DFS continues to slow down and ultimately patient succumbs. So we have to deep dive into more biological details to really gain something. Next slide. So these biological changes are actually leading to genomic instability, and the analysis of genomic instability will allow us to really now use more new drugs, or at least do research of the new drugs. The DNA damage, which is caused by platinum chemotherapy, cancer cells which are dormant, the stem cells, or with the power of EMT, they actually are not sensitive to this DNA damage by platinum. They come out, they survive, and they come out with a new clone. So our next philosophy, the next research has to dive into genomic data to really override this platinum resistance. Thank you very much.
Thank you. Thank you, sir. Dinesh sir, it's always pleasure listening to you. It's been a nice talk regarding the burden of disease in India and US compared with US. And in fact, we have a far more worse disease actually biologically also. It seems to behave much worse than it does in Western countries. And I think you have done a very good job of explaining how the resistance comes and how we intend to handle it in near future. I think we are trying to get something from our genomic profiling. Probably we will be able to get something more in near future. We will continue with our today's program. We have Dr. Jyoti Wadhwa. She is Associate Director in Medical Oncology and Hematology in Medanta Cancer Institute in Medanta Medicity Hospital, Gurugram. She is the DM from All India Institute of Medical Sciences. And she is going to speak on advancements in anti-angiogenic combinations in ovarian cancer. Dr. Jyoti Wadhwa, please.
Thank you. Hello, Dr. Coleman. I was there in a meeting yesterday, if you recall, the Imbibe meeting last evening here. So it's a pleasure listening to you again today. The topic that I'll be talking about today is advancements in anti-angiogenic combinations in ovarian cancer. So I'm sure you would all agree that anti-angiogenic treatment in ovarian cancer has had significant impact on the outcome. And I'll take you through the journey of anti-angiogenic agents over past 1 decade in ovarian cancer. They have been used not only in first-line ovarian cancer, but also for the treatment of both platinum-sensitive and platinum-resistant ovarian cancer. I will not be talking about the newer combinations of anti-angiogenic agents with PARP inhibitors due to paucity of time. That's very interesting and upcoming area of research. So in the first-line ovarian cancer, these are the 3 important studies. And GOG 218 is a pivotal trial which was a phase 3 study of the combination of pegcetacoplan with or without bevacizumab in stage 3 or 4 epithelial ovarian cancer. This is the schema. Herein, you would notice that the chemotherapy was used either with placebo or with bevacizumab for the duration of chemotherapy. And in the third arm, there was also a maintenance bev arm. What did this trial show to us? Just give me a minute. So this showed that the progression-free survival, the median PFS in the BEV followed by BEV maintenance was to the tune of 14 months compared to concurrent use of chemo with BEV of 11 months and just chemo leading to a median PFS of about 10 months. So this difference was significant. If we looked at only the biochemical progression, the difference was much more marked. The median PFS became 18 months with BEV followed by BEV maintenance compared to chemo alone arm. All these subgroups seem to benefit. The optimally debulked stage 3, the suboptimally debulked and stage 4, all these three groups seem to benefit with the addition of BEV followed by BEV maintenance, and patients benefited irrespective of their age as well. The overall survival, however, did not differ with BEV and BEV maintenance. So this is the summary of GOG 218 trial showing improvement in the progression-free survival. Subsequently, it was studied as to whether increasing the duration of bevacizumab from the standard of care then of 15 months to 30 months, doubling of duration of BEV, does that make a difference? And this is the BOOST trial. However, this did not show any improvement, any further improvement, either in PFS or overall survival. And therefore, 15 months of bevacizumab remains the current standard of care for first-line treatment of advanced ovarian cancer. This is the other study wherein attempt has been made to add immunotherapy with atezolizumab to first-line treatment. However, the study has been negative, both in the adjuvant setting and neoadjuvant setting. The addition of immuno did not matter. Coming to the recurrent platinum-resistant ovarian cancer, Dr. Pendharkar has beautifully covered this topic. Just to emphasize an important study, the Aurelia study, wherein platinum-resistant ovarian cancer patients were randomized 1:1 to receive either chemotherapy alone or chemotherapy with bevacizumab, either 2-weekly or 3-weekly regime till progression or undue toxicity. This showed that chemotherapy was of investigator's choice, and it included either paclitaxel or pegylated lipodox or topotecan. And all these three chemo combinations with BEV benefited from the addition of bevacizumab in terms of improvement in progression-free survival. Of note, the patients who had ascites seem to be benefiting much more compared to those without ascites. The overall survival, however, was not statistically significantly different. The response rates also improved significantly with the addition of bevacizumab to any of these three investigator choice chemotherapy drugs. So improvement in PFS and overall response rate, however, without any change in the overall survival. What about platinum-sensitive ovarian cancer? The recurrent platinum-sensitive disease does benefit from the addition of bevacizumab, as was shown in this trial, Ocean's trial. In this, the patients received either a chemo combination of gemcitabine with carboplatin or their use alone or with bevacizumab. And again, disease progression was the endpoint. The progression-free survival based on the investigator assessment was 12.4 months with the bevacizumab addition, and in the chemo alone arm, it was 8.4 months. The hazard ratio was 0.48. The overall survival, however, again, was not improved with the addition of bevacizumab. Objective responses, as have been seen earlier, were significantly improved with the addition of bevacizumab to the chemotherapy. So in the platinum-sensitive group of patients, there was a clear-cut benefit of addition of bevacizumab to gemcitabine and carboplatin chemotherapy backbone. So we have seen the use of bevacizumab making a significant difference to the outcome in patients with ovarian cancer. But what about beyond VEGF? So there has been a look at the other receptors. As we know, they do get compensatory upregulation. There is at least upregulation of the FGF and PDGF pathways. And we have a molecule by the name nintedanib, which is a triple angiokinase inhibitor. It targets not only VEGF, but also FGF and PDGF, thereby targeting endothelial cells, as well as pericytes and the smooth muscle cells. There has been a study, EGO-OVAR 12, which found the combination of nintedanib with paclitaxel and carboplatin, though not making any dent on the progression-free survival. But in the ICON-7 defined low-risk patient subgroup, that is those who were FIGO stage 2 or 3 and had less than 1 centimeter residual disease after debulking surgery, there seemed to be benefit with the addition of nintedanib to paclitaxel and carboplatin. Similarly, this is another agent, tibenanib, which is a peptide antibody that binds and neutralizes angiopoietin 1 and angiopoietin 2. And this is also undergoing active research. It has shown single agent activity in relapsed ovarian cancer in phase 1 study. And in phase 2 study, prolongation of PFS was documented when this tibenanib was combined with paclitaxel in recurrent ovarian cancer. So this is a trial, TriNova trial, which studied its combination with weekly paclitaxel. And it found some improvement in the progression-free survival to the tune of 7.2 months compared to 5.4 months. And the overall survival, however, seemed not getting affected statistically. Subsequently, there has been a TriNova 3 trial also. Now, drawing your attention to another newer anti-angiogenesis drug, sideranib, which was studied in this ICON-6 trial in relapsed platinum-sensitive ovarian cancer. So this sideranib actually targets VEGF receptor 1, 2, and 3. And this was studied in this 3-arm study, wherein one arm, the arm A, included only patients who received chemotherapy with placebo. The arm B included patients who got chemotherapy with sideranib, and arm C had, in addition to the concurrent use of sideranib, a maintenance sideranib arm. The treatment was continued for 18 months or until progression if they continued to show benefit. And the patients received any of these 3 chemos as the chemo option. This study, ICON-6 trial, showed an improvement in the progression-free survival with the maintenance sideranib arm. It was to the tune of 11 months. The median PFS with the maintenance sideranib, the hazard ratio of 0.57 when compared with the chemo alone arm. When the 3 arms, arm A, B, C, were compared, you would notice here that even though the concurrent sideranib made a difference, the median PFS improved to 10. However, it was further improved with the addition of maintenance sideranib. The overall survival also seemed to increase by about 2.7 months with the maintenance treatment with sideranib. So to summarize, this slide shows all the anti-angiogenic drugs which have been used in various studies, namely bevacizumab. I have shown you the results of bevacizumab in various settings, in frontline setting followed by maintenance, or in recurrent, both for platinum sensitive and platinum resistant ovarian cancer. Nintedanib, I did talk about this study wherein the low-risk subgroup seemed to benefit from the addition of nintedanib, a multi-angiokinase inhibitor. There has been a study of use of pazopanib as well in the primary maintenance therapy, though the results have not been very impressive. The sideranib seems to be making a difference. In fact, it's under study with PARP inhibitors as well, because the anti-angiogenic drugs do seem to induce genomic instability, thereby making the cells sensitive to PARP inhibitors. Thus, to summarize, anti-angiogenic agents in ovarian cancer do seem to have resulted in improvement in the progression-free survival. The response rates have definitely been enhanced. The menu of these anti-angiogenic drugs is ever expanding, and they have been able to successfully extend the post-treatment life expectancy of these patients with ovarian cancer. However, better combination therapies are definitely needed to dent the overall survival, because that's the much needed need of the hour, if I say. So thank you, Dr. Vaid, for giving me this opportunity, and I would end my talk here. Thank you once again.
Thank you. Thank you, Jyoti Madam. It's always wonderful listening to you, taking us through the VEGF inhibition, the various trials and the various agents that have been used. It's been really nice. I think you have done a wonderful job. We will continue with our session. Finally, it comes to me to give you, to send a take-home message to all the for this thing. I think we all agree that we have had a wonderful master class in oncology or gynec oncology on ovarian cancer. We all know that Indian ovarian cancer is slightly different from rest of the world. We have more younger patients and we have more aggressive disease. And our patients also seem to relapse faster, probably because they all, as Jyoti Madam also mentioned, and Pendarkar sir also mentioned, that most of us present with stage 3 disease. I think this advent of molecular biology and availability of NGS has thrown a very good options for us. We have genomic profile, which gives us an idea about the BRCA status of the patient, which also can give us the status of the HRD pathway, and also finally the angiogenic pathways and the MMR pathways also we are able to define in our particular patients. So looking at what we have at the moment in clinical practice, we can expect that first and foremost is to diagnose the patient early and treat him well with multimodality therapy. All patients should be offered either upfront surgery if possible or neoadjuvant chemotherapy followed by interval cytoreductive with or with. This will be followed by adjuvant taxane and platinum therapy along with bevacizumab maintenance. Apart from this, if patients are BRCA positive or HRD high, they should be offered olaparib maintenance as per SOLO-1 trial or olaparib plus bevacizumab maintenance as per POWER trial. Patients who are HRD negative can be offered bevacizumab maintenance or niraparib maintenance. Patients who ultimately relapse, as most of them will do in our patients, platinum sensitive recurrent disease should be offered standard of care, that is cisplatin based chemotherapy doublet. Once they achieve CR or PR, they should be offered maintenance with either olaparib or rucaparib, niraparib, and bevacizumab. We have evidence for all of those as per trials. Patients who are platinum sensitive, they can be offered niraparib, and patients who are partially sensitive can be offered niraparib plus niraparib as per QUADRA trials. Platinum resistant tumor should be treated with alternative second line or third line chemotherapy, which may include PEG liposomal doxorubicin, paclitaxel, or topotecan as per Aurelia trial. And each time patient relapses, we should try to get a NGS testing done and find a actionable, targetable mutation so that we can target them with our novel targeted agents. Patients with MSI high, dMMR, deficient MMR, or with a PD-L1 score of more than 1%, they can be offered immunotherapy with pembrolizumab. I think with this take-home message, we will hand over the mic to the organizer space. Dr. Ashok Vaid, sir.
I take this opportunity to thank everyone who has been part of the proceedings, and particularly all the presenters, Dr. Coleman, Dr. Pendarkar, Dr. Jyoti Vadva, and Dr. S.P. Kataria for moderating the various sessions. Of course, thanks are due to Rajesh, his team, and everyone at Mice Ideas contributed to the success, and particularly liaising and keeping a close coordination with Dr. Coleman for the simple reason that there was a time difference and there were communication gaps initially, but they closed them very well. And of course, thanks are due to all those who have contributed as our knowledge partners, and my associates at the Indian Oncology Foundation, our secretary, who provide us this platform for carrying out the various educational activities. As I said, there were 344 registrations at the beginning of this session. It has gone up, and I thank everyone who took time to participate and be a part of the proceedings this evening and in making this program a grand success. Rajesh, I thank you very much from the core of my heart for every session, every educational activity where your personal involvement is so very much, and that actually contributes and that leads the team at your end in a big way. Thank you very much. Stay safe. Have a great evening. See you soon enough. Thanks once again.